Good afternoon, everyone. I'm just going to record last of my class, which had problems with recording. So I'm just going to record the part that we missed out. If you guys have questions, just send me in the Facebook Messenger, okay? We'll be continuing with the October recalls. First question. Nurse says to her doctor that she is chronic hepatitis C carrier. What should the doctor do in this situation? Basically, they are asking this question. Option A, inform the hospital authorities. Option B, ask her to avoid contact procedures with patient. Option C, ask her to disclose her condition to the patient before doing procedures. Say her that it will not affect her work and that she can continue. Now, chronic hepatitis C is infective state. Patients are carriers and they can transmit the infection towards other people by exchange of body fluids, especially saliva, intercourse fluids, and blood. So if the patient is working in a hospital setting or he or she is a healthcare worker, then the best way is that we ask them not to involve themselves in the procedures that are prone for transmitting the infections. All right. Say to her that it will not affect her work and that she can continue is not a good option. We need to make sure about the patient and the healthcare worker's safety at this point. Ask her to avoid contact procedures with patient. We usually this is the best option to do. Ask her to disclose her condition to the patient. This is a private matter. She is not bound legally to disclose her condition. Informing the hospital authorities, if she was working in the hospital authority or hospital, then yes, usually we inform them and they just ask you to avoid any contact procedures with the patient. So here, B is the best option to pick. You guys can study it from this one as well. Let me just open up for you. Okay. So a person contacts hepatitis C when blood containing the virus comes into contact with their blood. Some healthcare workers may have an increased risk of contracting it when working with people with the virus. So there is no reason to exclude people with hepatitis C from any of the jobs. They just need to have standard precautionary measure that limit the blood to blood contact in healthcare setting. That's what they usually do. All right, next question. 80-year-old lady presented to emergency department from her care home, agitated now, and was having a severe agitation last night. She has bruises on her arms. What is the cause of her bruise? Number one is elder abuse in care home. B is caused due to restraining her while agitated. Number C is thrombocytopenia. Now, this is an 80-year-old lady who is being brought to emergency department from the nursing home because of agitation, and she was in her nursing care home was agitated as well. Option A could be a good option, but usually the elder abuse in care home, it's not very commonly physical. It's more neglect. So health neglect, hygiene neglect. These are the most common elder abuse in the nursing care facility. If the bruises were in places of non-accidental injury, then you have to have a high suspicion for it. Thrombocytopenia, we can't label patient having thrombocytopenia just by having bruises on her body. You need to have blood tests supporting the evidence of it. So the best option here, because they might have restrained her because she was agitated and she was harming herself or the others, then it's most likely caused by restraining her. So option B is correct here. Next question. Helen Jones is a 19-year-old secretary who presents with 1-year history of painless postcoital bleeding. She takes tri-sequential contraceptive pill, so which is like estrogen, progesterone in different cycles. Clinical examination is normal except for a degree of cervical erosion. Pap smear is inflammatory. What is the most appropriate management? Repeat pap smear after treatment with triple sulfa cream. This is the antifungal. Change oral contraceptive to more estrogenic balance. Reassure but review in 6 months. Refer for colposcopy or change OCP to more progesterogenic balance. So patient is 19, painless history of postcoital bleed of 1 year, is on contraceptive pill of different estrogen, progesterone concentration in different cycles. Everything is normal on examination except there's a erosion of the cervix. Pap smear is inflammatory, so it's unsatisfactory pap smear. Most appropriate management would be to repeat the pap smear. Option A is saying that you should repeat it after giving her antifungal. This is not a fungal infection that you want to treat, so option A is wrong here. Changing the OCP to more estrogen or progesteronic concentration is not going to help. If the option was that you stop her OCPs, then this will help because she is most likely having cervical ectropion. So changing the OCPs is not a good option as it's not going to do anything about the pap smear findings, nor it's going to help in the recovery of her cervical ectropion. The best option is that you offer her contraceptive method other than oral contraceptive pills. Refer for colposcopy. For colposcopy, you need to have a high suspicion for cancer. The pap smear is coming back as is inflammatory, which is unsatisfactory. So we need to repeat the pap smear. And if that pap smear is showing changes of concern, then you can refer to colposcopy. So I think the best option here is reassure, but review in 6 months. This way you won't miss anything in the patient. Okay. So if you look over here, if a patient is having a pap smear and HPV is not detected after doing the HPV testing, then you do the 5-year routinely testing. And if HPV 16, 18 not detected, then you do liquid-based cytology. If it is unsatisfactory, you usually repeat it. So in the last question, if option comes up that you repeat it or review the patient after 6 months or 6 weeks, that is the best option. Repeat it after giving antifungal cream is not a good option because the patient is not having a fungal infection. So reassure the patient because it's not cancer, and review or repeat the pap smear again. If the HPV is not 16, 18 and it's negative or low SIL, then you repeat it. And if it's not detected again and you do liquid-based cytology again, if it's low SIL and negative again, you repeat it in 12 months. And if it's detected of any kind, you refer for colposcopy. And if it's a high SIL or HPV 16-18, you refer the patient for colposcopy without any question. Okay. There are certain circumstances where the patient is referred for colposcopy. When on the first go of your HPV repeat test in 1 year, Female is 50 years of age, Aboriginal or Torres Strait Islander, woman who's overdue for her screening for more than 2 years, then you can refer the patient for liquid-based cytology and then refer for colposcopy. Next question. Gravida 2 para 1 with anti-D antibodies detected at 34 weeks during antenatal visit. During first trimester visit, there was no antibodies detected. Anti-D prophylaxis was given to her after delivery at previous pregnancy. She had blood transfusion history during the orthopedic surgery 10 months ago. What is the reason for her antibody detection during this visit? Blood transfusion, fetal-maternal hemorrhage, change of partner. The most common cause of anti-D antibodies formation in the maternal blood is because of the fetal-maternal hemorrhage. Patient had blood transfusion 10 months ago before the pregnancy. It's very, very less likely that the patient had anti-D antibodies because of the blood transfusion. Change of partner could be one of the reasons, but it's less common. Most common is that mother and fetus has a hemorrhage exchange with each other, or there's a blood exchange between the mother and the fetus. So option B is the correct option here. You guys can study anything about NTD from here, or you can just study from your JM as well. Both are very good resources. NTD, so RH negative blood is pregnant, mother is pregnant with a RH positive baby, and baby's immune system produces antibodies against the mother's blood. So why this happens? Because there is exchange in the blood. So anti-D immunoglobulin injections in the first trimester and then in the third trimester helps mom protect the baby against forming these antibodies. And it can prevent the hemolytic disease of the newborn. Okay. All right. Next question. 38-year-old builder had an acute back pain which subsided over 24 hours. He now complains of increasing numbness and tingling in both legs and poor bladder and bowel control. Which one of the following should be your first step in management? Physiotherapy, strict bed rest with pelvic traction, epidural local anesthesia, spinal manipulation, or MRI. Now, this is a young lad with acute back pain that resolved over 24 hours, but he now has neurological symptoms of very, very concerning neurological symptoms, which is numbness and tingling in both legs with the loss of or poor bowel and bladder control. Anyone who's coming with low back pain and poor bowel and bladder control or symptoms of motor sensory neurodeficits in the lower limb associated with central anesthesia, our first thought is the patient might have cauda syndrome. So the first appropriate management is imaging in that patient. Physiotherapy is not going to help with cauda equina. Strict bed rest with pelvic traction is not going to help as we don't know the cause for that. Epidural local anesthesia is not going to help. Spinal manipulation we don't do as it can worsen the cauda equina syndrome symptoms. So the best one is that we do an MRI, CT scan, and we talk to the neurosurgeons. And they will give you advice about what to do as a further management of this patient, what kind of positioning they want the patient to be in, or whether they want the patient, because most of the time, majority of the time, these patients get transferred to the neurosurgical facility where they get treated under the neurosurgical team, because this is an emergency. It's a spinal emergency because it can cause permanent paralysis, especially in a young patient like this one. So don't take any chances. The first step is appropriately do the imaging. This is the New South Wales Emergency Department guideline. Basically tells you what to do in all type of low back pain. But for Kodak-Pointner syndrome, if you look over here, sign and symptoms, you might have. So this is the spinal cord. This is the conomedullaris, and this is the chordoiquina. So spinal cord or conomedullaris is L1 region, and below that you have chordoiquina symptoms. So the patient can present with low back pain, saddle anesthesia, fecal incontinence, constipation, or loss of the anal tone. On PR examinations, always do the PR examination of all the patients who are coming with low back pain. They will complain of urinary symptoms, could be incontinence and could be overflow as well. And if incontinence is present, it's a very poor prognostic sign. Causes, it can be because of the disc herniation, as you can see, at L5 or L4 or L5S1 region. So conomedullaris is L1. Beneath that, chordoiquina is present usually, and there the compression of the spinal cord can happen. Now, it's less likely to be with fractures, neoplasias, infections, or it can be because of the iatrogenic causes as well. When signs and symptoms of chordoiquina syndrome are present, urgent senior ED doctor review should be sought, and urgent MRI is the investigation of choice. If you don't have the facility available, they will mention sometimes in the question that you need to do a CT scan. Okay. Urgent spinal surgery referral should be made without delay and prior to investigation being complete, because this patient will require urgent surgical decompression. Timing of surgery is controversial and will be decided upon clinical and radiological review of the images by the spinal surgeon. Next question. A patient with dysuria, frequency, and incontinence. What is your next appropriate action? So patient is coming with urinary incontinence, but also has symptoms of dysuria and frequency as well. Would you do urine culture, give oxybutynine on first presentation, or do ultrasound pelvis? So most of the time, any patient, male or female, who are coming with urinary incontinence, doesn't matter if they have signs and symptoms of urine tract infection or not. We always start with urine culture and sensitivity, because the most common cause of urinary incontinence in the elderly age people is the urine tract infection. It's not always the pelvic floor problem, or it's not always the bladder detrusor muscle overactivity. It can be most of the time caused by the urinary tract infection. So the first line in investigation in urinary incontinence doesn't matter urgency or stress or mixed type. We always do a urine culture. You guys can study it from RACGP guideline, or it's also in JM, very well written. Either is fine. So you do an assessment by evaluating, taking a detailed history, medication review, very important, focused examination, and basic investigation. So basic investigation are these. We do a urine analysis with microscopy and culture. Asymptomatic bacteriuria in population of elderly is very common, and we need to be cautious about interpreting the positive cultures. Bladder chart, portable bladder scan for post-void residual urine. If it is normally, the bladder has a capacity of 500 mils, but residual volume of more than 100 should always require further investigation. Then you can do ultrasound of the genitourinary tract, and then further you can do like urodynamic studies as well. Okay. Next question. A patient with history of severe backache took 10 to 12 paracetamol tablets for 3 days. Now complaining of abdominal pain and other things. It looks like liver problem. What is the next step? Check paracetamol level or check LFTs. So when you're concerned about a paracetamol poisoning and a patient is taking a lot of paracetamol tablets, even though they're coming with the liver failure sign and symptoms, the first concern is that you check the paracetamol levels. But as this patient is coming in day 3, most of the time we don't check the paracetamol level straight away. If it is more than 8 hours, we give N-acetylcysteine solution, and then we check paracetamol levels because we want to treat the poisoning first. So if you look over here, this is the chart for paracetamol poisoning used all over Australia. So if you're coming in less than 2 hours with paracetamol ingestion of more than 200 milligram, more than 1 gram per kg, or you're coming with hepatotoxicity, intravenous paracetamol errors or overdoses, or you're coming with more than 200 milligram per kg of paracetamol ingestion over 48 to 72-hour period, then these are the things we should do. If less than 2 hours, don't bother with the paracetamol levels or ALT levels. Give activity charcoal so we can get it out of the stomach. If the patient is coming with 2 to 8 hours, you do the paracetamol levels and you check the ALT as well. If the paracetamol levels are within the normal range on nomogram, then you don't do anything. But if it is over the treatment line, you start the patient on the N-acetylcysteine solution. If patient is coming in more than 8 hours, we don't do anything at the start. We start the patient on NAC infusion. Then we measure the paracetamol and liver function test. And if the paracetamol levels are coming up the treatment line on the nomogram, we continue the treatment. And if it's been 24 hours after the dose, we check the ALT levels. If they are less than 50, we continue the infusion and measure the ALT level at the end of the infusion itself. If it's less than 50, we stop it. If it's more than 50, if it's less than 50, we stop it and we don't do any further treatment. So level is also important. You can study it from here as well. It's more in detail. Next, 25-year-old with 1 centimeter cyst mass from nipple, 2 centimeter in size, previously had pain but now asymptomatic. Normal examination. What is the management? Reassure, follow-up, or surgery. So this patient is coming, young patient coming with breast mass, which was previously painful but now painless, but persisting mass. What we always do is this: we do triple test. Physical examination has been done, no imaging is done, or no needle biopsy is done. So in this question, the best option would be you follow up the patient. We don't reassure. We will keep following up and do the imaging like ultrasonography in her age group. And if more than 35 or 45 years of age, we will do mammogram. But we will not, excuse me, we will not leave this patient. We will not reassure this patient and we will not go for surgery. We will do the triple testing. Next question. 14-year-old girl is brought in by her mother, who is concerned about her daughter's low mood and tearfulness. 6 months of feeling sad and anxious with decreased energy levels, loss of interest. School grades have deteriorated, occasional suicide thoughts, but no plan. Which of the following is the most appropriate step? So this patient is coming with major depressive disorder symptoms, and they're asking you the most appropriate step. If you look through the stepwise guideline here, it says the first step should be cognitive behavioral therapy. Encouraging physical and social activities is a part of it. But appropriate treatment and management is cognitive behavioral therapy. After commencing patient of cognitive behavioral therapy, simultaneously we also commence the patient on medication as well. But the first step is always cognitive behavioral therapy. Arranging admission is when the patient has attempted suicide or is having severe major depressive disorder with psychotic symptoms. So main objective is complete remission of the depression symptoms, lifestyle modification, and then first step is that you do psychological therapy. Simultaneously, you do pharmacotherapy. So in the question, if you don't have medication as a first option, always select the cognitive behavioral therapy. But if they have given you options of cognitive behavioral therapy and medications together, then that will be the best option to select. Okay. Next question. An elderly population is coming with confusion, aggression, and violence. Her partial pressure of oxygen is reduced. Patient had pneumonia. What is the management? So they are talking about a delirious patient coming with agitation and aggressiveness secondary to hypoxia. And we want to do management in this patient to control agitation. So whenever a patient is agitated and aggressive and violent, they are not going to accept or listen to verbal de-escalation, but that should always be done. The best option here would be to calm her down by giving her IM haloperidol. If the patient was confused, agitated, but not violent, you can always try with the oral option first. But if the patient is physically harming themselves or surrounding patients, then the best option is IM or IV. Acutely disturbed patient, non-pharmacological management should always be done first. Talk calmly, make sure environment is less stimulating, make sure that their hearing aid is in place, they have their glasses, don't crowd the patient, make sure your body language is not threatening. Um, then asking a family member to be present so that a familiar face is there. And then if you're not successful with non-pharmacological, then you can do this. You use the antipsychotic medication. Most of the time we use haloperidol. You can give oral, but IM is much more better, especially in acutely agitated and violent patients. You can also give lorazepam, midazolam as well. Midazolam is IM as well. Lorazepam is the oral formulation, or we can offer them risperidone. But all of these should be used very carefully, especially if the patient has Lewy body dementia, prolonged QTC, um, progressive supranuclear palsy, or multiple system atrophy. You should be very careful about that. A patient is coming to you with band-like headache, flickering movement spotted on the eyes. It lasts for 4 hours. Which of the following is the management? So they are talking about migraine here. It can also happen, not all of the time. It's like a band-like headache, but it can also, unilateral headache, but it can also occur like a band-like headache, and patient can have some nystagmus as well, but it's very transient and it's always triggering. And flickering movements is patient describing the flickering lights they see from the corner of their eyes. So this is migraine typical. Amitriptyline, pregabalin. Pregabalin usually not used for migraine, but amitriptyline is used as a prophylaxis for migraine. And most commonly, the medication used for treating acute migraine is triptans and other simple analgesics. So best option here is intranasal. We can also give it intranasally. If you look over here, migraine, acute migraines, You can use steroids, paracetamol, aspirin, doses 900 to 1000 milligram, or you can use NSAIDs, antiemetics as well. Triptans is very effective in treating migraines, but it can come in the tablet form. It can come as subcutaneous injections or nasal sprays as well. If the patient is not responding to triptans, you can try steroids as well. Okay, but these are the preventive therapies: amitriptyline, candesartan, especially in patients who are having hypertension, but also migraine. Then you can use ARB as well. It can help. Nortriptyline, pizotyphin, propanolol, sodium valproate, topiramate, and verapamil. These are the prophylactic agent for migraines. And the prophylactic agent for migraines are given whenever a patient is having more than 3 or 4 attacks in the last month or so, or 5 attacks in the last 3 months. These are recurrent migraines and they should be treated with prophylactic therapy. Patient with history of thyroidectomy or papillary tumor started bleeding post-surgery with the compromise of the airway. So hematoma post-thyroidectomy. What do you want to do? Remove the layers or call surgical team? So we don't wait for the surgical team to arrive. The best is, because the patient's airway is being compromised, we remove the layer and try to remove the hematoma. So scooping is done. So you do the skin exposure, you cut the sutures, you open the skin and open the muscles, and then you pack the wound. So opening the skin and opening the muscles, you're allowing the hematoma to drain, and packing the wound is you're preventing any fluid to come out. Okay. So it's signs of air obstruction are always like upper respiratory tract obstruction causing stridor, desaturating on probe, and difficulty breathing. So these are the things that we usually do. Okay. Next question. A patient with facial trauma fracture in respiratory distress, which of the following is the management option? Oral intubation, tracheostomy, or nasal tube intubation? If you look at the critical airway guidelines for the ICU guys in Australia, it recommends that even though if it's a difficult airway, always try intubation through the mouth. So difficult intubation guidelines, this is for facial trauma as well. So when you do face mask ventilation and tracheal intubation is your plan A. You do laryngoscopy and try to do tracheal intubation through the oral cavity by laryngoscope. If you're failed, then you can do supraglottic airway device. It can wake the patient up, and then you can intubate trachea through the supraglottic airway device, or you can do tracheostomy or cricothyroidotomy. Cricothyroidotomy is the last resort after supraglottic airway device fails. Okay, but first one is always oral intubation through the ETT. This one. It's a big book for difficult airway algorithms and checklists. If you guys want to give it a read, this is a good guideline for that. Oh, sorry. Next question is, a patient presented with mouth and genital ulcers but now has developed uveitis. This is Beckett syndrome, guys. It's a vasculitis that causes oral ulcers, genital ulcers, joint pains, but can also present with eye symptoms of bilateral uveitis or bilateral conjunctivitis of unknown cause. It's an autoimmune disorder. Patient can also have bloody diarrhea as well. So most of the time you can, it comes in triad of it. And the most appropriate treatment for uveitis, mouth ulcer, genital ulcers, or Beckett disease in total is that you give steroids, oral steroids. You can give mouthwash to the patient, but that is a good option as well. But we don't give steroid eye drops. We give symptomatic treatment for uveitis, and we treat the underlying cause with the oral steroids. If you look over here, you give steroids. Methylprednisolone, prednisone, or dexamethasone. This is the medication that we give. Or if you can look at the medication summary, immunosuppressive therapy can be given, immunomodulators or DMARDs can be given as well. But most of the time, we give steroids as the treatment of Beckett disease. Next question, a patient got Indocet for gout. Indocet is indomethacin. Later on, he developed congestive cardiac failure and was already on congestive cardiac failure therapy with furosemide. What to do next? Stop Indocet, increase furosemide, give NSAID. Always remember that giving NSAID with furosemide, especially in patients with congestive cardiac failure, can cause worsening of symptoms of cardiac failure itself and can also affect your kidneys, because your kidneys are required in cardiac failure, especially cardiac failure with fluid overload for diuresis. And if NSAIDs is being given for a long time, especially a strong NSAID like Indocet, it can cause AKI in congestive cardiac failure, making symptoms of congestive cardiac failure worse, and your diuresis will become difficult as well. So you can always start the patient on another acute gout management, which is steroid. So advice is, if a patient is on furosemide, avoid NSAIDs altogether in those patients or use another therapy. So best option is you stop in Indocet, continue furosemide. Increasing the furosemide is not going to help because it's still going to interact with the NSAID. Giving them together is called double whammy. They will cause kidney injury and worsen the symptoms of the congestive cardiac failure. Why should NSAIDs not be used with furosemide? If you're taking NSAID regularly, your blood pressure may not be as controlled, and it can also cause ear damage, especially with high doses. This may be more likely to develop if you're taking it with furosemide. If you have high blood pressure, experts recommend you avoid NSAIDs. And why it's contraindicated in heart failure? Because it impairs the renal function with in patients with a decreased effective circulative volume, and it can cause water and sodium retention and increases the chances of fluid overload in the patients with the congestive cardiac failure. Okay, guys, next one. A woman has an IUCD and got diagnosed with bacterial vaginosis. What would you do? Option A, contact tracing. Option B, screen for chlamydia. Or option C, IUCD, remove it. So if you look at the guidelines from STI Management Australia, bacterial vaginosis, what it says about the IUCD, they have different conditions, special conditions they have. So we all know bacterial vaginosis is caused by Gardnerella vaginalis. It's a bacteria that lives within our vagina, and very common in females who have female sexual partners, and reoccurrence is also increased. Patient present with malodorous vaginal discharge, thin white or grayish homogeneous vaginal discharge. Most of the time, they're asymptomatic as well. Complications, it can cause PID, it can cause increases of having other UTI, STI diseases like chlamydia, gonorrhea, herpes simplex type 2, or HIV infection. But in a patient who's pregnant, it can cause abortion spontaneously, it can cause preterm labor or chorioamnionitis, and if it's a postpartum female, it can cause increased risk of developing endometritis. Diagnosis is that we do a high vaginal swab, and if the patient has elevated vaginal pH or VIF test is positive and you have blue cells on microscopy, it's diagnosed. We manage it with metronidazole for 7 days, twice daily, or clindamycin as an alternative. If the patient had IUDs, if the patient is being planned for IUDs and discovered to have bacterial vaginosis, it does not delay the IUCD insertion. And copper IUCD have been associated with the high risk of bacterial vaginosis. If a patient has IUCD and then develop vaginosis, then you treat as recommended. But if they have recurrent bacterial vaginosis, you should remove the copper IUD. So patient is having first episode. If they're having recurrent episode, then you should remove the IUCD. There, guys. So our option is we don't do contact tracing in bacterial vaginosis. We are not going to take out the IUCD. We are going to screen for chlamydia. Clear? Next one. A child with recurrent upper respiratory tract infections and microcytic anemia, which one of the following is the most likely provisional diagnosis? So a patient who's coming with recurrent upper respiratory tract and microcytic anemia, always think about cystic fibrosis. Because recurrent upper respiratory tract infections most commonly associated with cystic fibrosis. Celiac will come with malabsorptive syndrome symptoms. Like patient is having failure to thrive, is having iron deficiency anemia, vitamin D deficiency, patient is having vitamin B12 deficiency symptoms, vitamin K deficiency symptoms, large bowel movements, protruded belly, dry coarse skin. These are celiac symptoms. But for cystic fibrosis, it's recurrent chest infection, failure to thrive, and also malabsorptive syndrome. But recurrent chest infection is associated with cystic fibrosis. So it's a disorder that affects the lung and digestive system, and patient present with recurrent chest infections. So what are the symptoms? Persistent cough, difficulty breathing, wheezing, frequent lung infection, salty sweat, tiredness, lethargy, reduced ability to exercise, poor growth of weight gain, frequent visit to the toilet, poor appetite, diabetes, and infertility in males. You can also study celiac disease from this one. All right, guys, I think we have the recording from 41 questions onward. So we will put those recording on and you have the recording till question 41. Okay, thank you so much.